So yeah, I just tweeted it out to everybody I could possibly think of, all the possible news wires, Kaiser Health News and Kaiser Family Foundation and NPR and a whole bunch. So we'll see if anything comes of it. But that.
That's good.
Well, and I went on YouTube and what do we call it? I don't know. Anyway, I signed up, and so I was, I think, number 48, and then I was on there only a minute or so, and two more people signed up after me, and so yeah, so that was kind of cool.
Oh, so we're halfway there, Rick. You need 100, you said, right?
Yeah, we need 100. So we'll keep asking and we'll keep pushing. I mean, my goal again is hopefully we'll have it done by the quarter. We'll keep pushing and pushing and pushing. And then um, as far as the breast cancer group is concerned, I mean, I've already had a couple of people send me their email addresses. So, I think it's really important for people on this call who are regulars, who know and understand what they get out of this call, to let other people know that maybe in the breast cancer world that we're doing the same thing now for breast cancer.
Well, I let my sister-in-law know. Whether she'll join or not, I don't know.
Well,
she's got I forget. I always forget. She's got the stage 4. It's not good. It's not the good kind. If there's any kind of good kind, it's
right.
Oh, I can't think of it.
Triple negative?
No, it's the one that shows up as more as a rash than a lump. Damn, I always go blank on that one. I try to tell you. It's a nasty one.
Okay.
If I think about it, I'll tell you. But I did let her know. Hopefully, she'll join. She's kind of in a bad place right now. She needs an inner conversations of her own.
Well, I don't know how Tanya and Helen are going to pitch this, and it may be that they pitch it in a way that it is more of an inner conversations call. I mean, I've left it totally up to them as to where they want to make it, how they want to make it happen. I don't want to be telling them how to run their own call.
Right.
We'll see. I mean, I'm gonna.
Are you gonna? Go ahead.
Oh, I'm not going to take an active part because I don't think a man's voice on that call is helpful, but I will listen in to the first, and I'll send them messages. I can send them through the chat window. I can send them messages
and help them out with the names.
I could do that. Yeah, I mean, we're going to have a session on Wednesday morning. I'm going to show them how to do all of that. But if they
show them how to do it, yeah,
do it. So, and Renata's going to on that.
I really doubt that in time. I really doubt it in time they'll have problems with it being undersubscribed. I think the problem will be oversubscription in my estimation, because my experience is that women love to show up. Women love to tell their story.
Right.
If anything, they congregate, and so they could have challenges with numbers in the oversubscription end, if anything.
Well, that'll be good. I hope so. Anyway,
I don't think it'll be a problem with oversubscription, in the sense that as we find out where the interest lies, we're going to have to break the group into subgroups, because having just one general breast cancer call is probably not going to work in the longer run. So we'll finish up either breaking it up by the type of breast cancer or maybe by age, so that we'll have an older women's group and a younger women's group. But we don't, the first thing we've got to do is get some momentum and then see where we go from there.
Yeah, my experience in watching and being part of a women's group, essentially for a couple of years, is that the place where the most effort is needed is in initial diagnosis. That's the same thing with men. I mean, that's where people break down
Mm-hmm.
and just don't know where to turn, don't know where to go, think the end of the world's coming, and they need a lot of attention. So it might be wise to have a newly diagnosed group as well.
Well, I think it's going to be indicated by who we get on the call. And
Right.
if we, I mean, rather than,
Yeah, I'm sure it'll shake out with time. I'm sure they'll figure out what they need to do. But oh, by the way, my sister-in-law has inflammatory breast cancer.
Inflammatory. I'm not.
Yeah.
I don't even know that. But yeah. I mean, I think that rather than us saying, well, we're setting up a newly diagnosed or an inflammatory breast cancer or a triple negative, I think we'll see who attends. And once we get a core of people that have a particular interest, we can break that off and then continue and keep going like that. And we'll see how it goes. But I think the big thing is to get the word out. We just have to let people know that we're holding the call, and it'll build from there. And it's not easy to get the word out, as I've found out.
Well, I did post on Facebook, and I always get a notice of how many people have looked.
Yeah, but
and
it's
that particular notice shows about 60 people,
right.
Whereas most calls or most postings get 5, 10, 15 at the most.
Right, but
so maybe that's a good sign.
Yeah, but Jake, I'm talking about getting it out to thousands or tens of thousands, which is what we've got to do. I don't, 50.
You can't handle thousands on the call.
Well, we can't handle thousands on the call, but we can get it out to thousands, and there will only be tens that will subscribe.
Well, true.
I mean, the fact is that people hear about it, but they're not going to all call. I mean, the conversion rate is very, very low.
Right.
So you've got to get it out, and God forbid we were oversubscribed, then we would worry. That should be our worst problem. But we've got to get the word out to as many people as we can, and so for example, if NPR or Kaiser Health News picked up on this and said, "Wow, this is a great idea. We don't know, and we'd like to do a story on this," it would be
that would be cool.
because then everything we do, and we're going to get moderators coming in and saying, well, why can't we start one of these for ovarian cancer or for Parkinson's or for this or for that, which is really what we're looking at. Anyway, we should probably get this call underway, and I was thinking there might be a couple more people who had said they were going to come in, but they might come in later. I guess the football tonight is a big appeal, not to me because I'm not interested in any of those teams, but it is to other people. So I see Jake and Peter and Gary and Tom Van Zant, and that's it. Anyone else?
That's it so far.
That's it. Okay, a nice small group. So let me just check and see who wants to talk about anything, and then we'll go from there. Jake, first with you.
No, I gave you my blood results last week, so I don't really have anything new.
Okay. Mr. Van Zant, how about you? Can we discuss anything that you'd like?
I did a little research into the tumor debulking, and that seems to be like a fairly new thing.
It is.
So that a lot of these doctors, I don't think they're even up to speed on it.
We can discuss it with pleasure. Gary, anything for you tonight?
I don't have anything in particular. I'll just join in.
Just join in. Okay. And Peter, anything for you tonight?
Uh, Not directly related to me, but related to my world. I have a question about a test that I couldn't find any information about.
Sure, we will talk about that. So let's start off with then this tumor debulking, because it's an interesting topic. And historically, I mean, I know a little bit about it, not a huge amount, but historically, it was always something that Mayo did. A Mayo Clinic would always do, and they would always do it with surgery. So historically, Mayo Clinic, particularly the main one in Rochester, Minnesota, would oftentimes debulk tumors even when they were stage 3 and stage 4 metastasized, even locally and more advanced. And I was aware of this going back to around 2007, 2008, and it was always controversial. And I would say probably about 3 years ago, I became aware of a study that clinical trial that Memorial Sloan Kettering was doing, where they too were debulking metastasized tumors with a radical prostatectomy early on. And they ran a trial. I don't think that there were that many people in it. I'll see if I can find I have a link for it. So I've got to try and find that link. But they published after 22 months. And what they found was that there was certainly a better, if I remember correctly, there was a much better delay or greater delay in disease progression. But it was really after a very short period of time. Now, as they were doing this, there were other people that were also doing some experimentation with radiation. I want to say Anderson, but I'm not sure. But I think it was NCCN hospitals. And what we started seeing were more and more people, or hearing about more and more people that were getting their primary tumor debulked, either with surgery or with radiation. And this past year, I think there were at least 3 or 4 guys in our group that went through that procedure. And I remember that Ken Anderson, who was one of the guys, raised it probably about 6 months ago. And he said to me that that Korn was talking to him about surgery, and I said, I wouldn't do surgery. Absolutely not. I think he even has scheduled a surgery date. And I said, I don't see the risk in doing surgery. I mean, if you're going to do it with radiation, because the side effects are going to be less significant than the surgical side effects. And you don't need to undergo the surgery. And so he and Korn huddled, and in the end, he did do it with surgery. He did do it with radiation, but he did it with IMRT. So he went through 20 odd sessions of fractionated treatment, and in addition, and he was the first man I heard that did this, that Korn also recommended that he do pelvic girdle radiation. So they radiated his whole pelvic girdle, even though we knew he had bone metastasis, which I found really strange. I mean, I questioned it, and and MD Anderson and Paul Korn, who I have great respect for, said, no, we think you should do it. So he went ahead and did it. So he finished up doing about 45 sessions. He could have squeezed the prostate radiation into 4 or 5 with CyberKnife, but the guy that he was seeing, this guy Lucas in Phoenix, didn't have the equipment, and he just decided he didn't want to go through finding another doc or a different doc. Dr. Steve did it at Kaiser. He did not get pelvic girdle radiation, but he just went through 5 or 6 sessions of the CyberKnife and debulked his tumor. Interestingly enough, in I think both Steve's case and I think Ken's case, there was no cancer that they could actually see in the prostate, so that whatever treatment they'd done beforehand, which would have been a combination of hormone therapy, first-line hormone therapy, and chemotherapy, had eliminated all of the cancer in the prostate. It had not eliminated the cancer in the bones or other places. So, so that's really the what I know about it. I'm just looking at the note that you sent me, Tom. So Tom says to me that his oncologist feels that there's too much risk in going through the debulking, and he's in a good place. So I would respond to that in a couple of ways. I'm going to sort of repeat what Dr. Steve said. By the way, Dr. Steve said he might be on this call tonight, but I don't know if we'll see if he makes it, because if he is, he can talk to this. And if not, I can give you an update on him, because we talked at length earlier this week. Steve says that in his experience with ovarian cancer, it was always smart and wise to debulk the primary. And there is other research that some of you may be aware of that suggests that the prostate cancer cells that are in the primary tumor are more aggressive and behave differently to those that have metastasized. So it's better to get rid of all those cells that are in the primary tumor. And as Steve said, based on his own experience for years and years and years, he wanted to debulk the primary tumor. And, you know, what we're hearing and seeing is that more and more people are thinking like that. So, you know, I would say to you, Tom, that you have to take the research that you're finding and show it to your guy. Is it Gandisman? Is that his name?
Gynasman.
Yeah.
Gynasman.
Gynasman. So you're going to have to show it to Gynasman. I mean, the only way that you can convince these guys is to have them talk to either see research or talk to people like Korn. And, you know, he will know Paul Korn for sure, because Paul Korn's he's a nationally recognized GU med onc. He's like Charles Ryan. And you can say, look, you know, I'm aware of guys in my support group being seen by docs like Paul Korn, where they're recommending debulking after the surgery, after the chemo. Peter, do you have anything that you want to add to that, or to elaborate?
No, I'm certainly not an expert on this. No, I don't. I got a little bit confused before when you were talking about when they went back and looked at the prostate and saw no cancer in it. I wasn't
Right.
Maybe I misheard you. I wasn't sure what you meant by that.
Exactly that. I mean, it was very confusing. I mean, the day before Steve was supposed to start his um, his radiation, SBRT, stereotactic body radiation. He'd gone in, and they had, or 2 days before, and they had put in the gold fiduciaries, and when they did that, they said to him, should we do a biopsy at the same time? Because Steve never had a biopsy, because he had metastasized cancer.
Huh.
And he said, sure. And then when they analyzed the biopsy, they only took a couple of cores. There was no cancer that they found, even though they did it. They didn't do an MRI, they didn't do a fusion biopsy, but they looked at they did a transrectal ultrasound, grayscale, and they saw what they thought were indication of lesions, and they didn't find anything.
How can they consider prostate cancer if it doesn't originate in the prostate, if there's nothing there?
Well,
I don't understand.
It did originate in the prostate, and it metastasized.
But and then disappeared in the prostate?
Right. Treatment, the combination of the chemotherapy and the hormone therapy that he'd already done nailed it.
Okay, so treatment got rid of it. It did originate in the prostate, but through treatment it dissipated.
Well, that's what we would assume. I mean,
okay, that's
sure.
I got confused.
But
that's what happened with me. I had a CT scan about 1.5 years ago, and it did not show any cancer in my prostate. So it sounds like the original pre-treatment did clear up the prostate cancer, even though I have it in my bones.
And the same thing with Ken Anderson.
Right.
So, you might argue, well, look, if there isn't any there, why go through the radiation? That, I think, would be a stronger case than why should we do this? You seem to be handling your disease well. Tom, did you? I cannot remember. I don't. I'm looking for something else here. I don't have your. I don't have up in front of me. Were you diagnosed metastasized?
Yes.
And did they ever do an original biopsy, or did they just take you into treatment?
Yeah, I had the rectal biopsy of the prostate, and then I had another biopsy of the lymph node to prove that it was prostate cancer in a lymph node.
Okay.
And it was. I have not had chemo though.
Right. And what was the what original Gleason did they give you?
The original score I was given was a 7, but then after I went down to Antonarakis, he said he thinks it's more like an 8 or higher. And then when I checked back with the hospital that gave me the 7, they said, well, it depends on what slide you look at.
And was that 7 a 4 plus 3 or a 3 plus 4?
I don't remember that.
Okay, because that's really important. But then if you're saying that that originally there was confusion as to whether you were a 7 or an 8, I mean, we know if you were an 8, at least one number had to be 4 or greater.
Yeah, well, Antonarakis seemed confused when he first looked at all my charts and numbers, and he said, I don't understand why we're having trouble controlling your PSA if you're a 7. And he said, after having studied this a while, I think I understand you're not a 7, you're an 8.
Mm-hmm.
And I said, I think you have a more aggressive cancer than they think.
Mm-hmm.
And he wanted me on bicalutamide immediately.
Right.
You know.
Well, I will look for the. I know I have it. I just cannot find the. I can't find the reference right now. So we'll keep talking. I want to welcome a couple more people, and we're not done with you yet. But let me just welcome. I see that Christine and David Sibley are with us, and that Dr. George is with us.
Guys.
So I know Christine and David have got an update for us. George, did you need some time tonight?
No, I'm good. I got my appointment this week on Wednesday, so I'll probably have some more after that.
Okay, if you want to review what you want to cover with them, we can do that with you with pleasure. We'll have time tonight. We don't have, it's not a big call.
Okay.
Okay, so just to who else wants to talk about debulking? Okay. Well, if there's no other discussion around the debulking, Tom, I mean, my feeling is that if it were me and I was faced with the decision, I would probably want to get it debulked if I could do it with cyberknife or stereotactic body radiation, where I could do it in 4 or 5 shots. I really don't know whether I would want to go to the 25 fractions that would be required for my pelvic girdle, because I have trouble seeing how pelvic girdle radiation can be that helpful when it's already metastasized. And I was really surprised that MD Anderson wanted to do that, but there is a reason to do it. But I think I probably would certainly consider, if me, I would consider the primary, and it would be definitely with radiation.
Rick, one question that comes to my mind is, whether there's extracapillary extension, whether the original tumor vesicles or the lymph nodes and so forth, and whether that would be a factor in why you would do pelvic girdle as afterwards, and not just prostate.
Well, I think that Tom, could you just turn your volume down just a tad, because we're getting feedback from you. I think that when they do the stereotactic, they do radiate the prostate bed. So if there's extraprostatic extension, they're going to probably nail that in the process. What I'm not sure about is what sort of screening they do ahead of time to determine the field of radiation. That's something that Steve would have to tell us, because he went through that, and I just don't know. Even if I still don't know whether it would justify, I still don't know for me personally whether I could justify the pelvic girdle radiation, even if there was extra prostatic extension. Don't know. Just don't know. But I mean, there's no right answer, Peter.
Right.
Tom, I'm not sure if this is applicable to what you're talking about, because I haven't had a chance to actually read this whole article. But New Prostate Cancer Info Link, Alan Adele posted a thing about adjuvant ADT radiation along with ADT, and the effects that it had on the T cells, tracking down rogue cancer cells. So it may not be applicable, but I put the link in the box there. You might want to just click on it and check it out at your leisure. Like I said, I haven't had a chance to read it yet, but it's a pretty long article. But Alan Odell usually writes good stuff.
Yeah, he does. He does. We need to get him on one of these calls. I mean, we can do that. But we need to put him on one of these calls, and you know, we can discuss with him about some of these issues that he writes extensively on, or maybe we'll get him to do a plenary for us one of these days.
Is he a doctor or a researcher?
Neither.
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 Okay.
No, he's pretty amazing. Pretty
He
amazing.
really is, yeah.
Yeah, he is pretty amazing. He's a really, really nice guy too. Very, very nice guy. Okay, well, Tom, I will keep looking for this article. If I find it during the meeting, I'll tell you. I'll post it in the box. If I don't, I'll send it to you later. But I know I've got a reference to. I know I've got a reference to the study. I've just got to find it. So, okay. So moving along. Let's go to Christine and David, and you can give us an update about your situation. We haven't heard from you for a while, so we're very pleased to hear both your voices. And you know, tell us where you're going and what the issues are. Tell the guys what the issues are, and you know, let's see if we can at least do a little bit of troubleshooting for you.
Hi, Rick. This is Christine. My dad just stepped in the back for a minute. He hasn't been feeling that great.
Okay.
You want to, are you going to go the rest? Oh, okay. Yeah, he's not feeling that good. So he's been on his third cycle of Taxotere.
Mm-hmm.
And the PSA still seems to be rising. It's higher than it was originally. And he had his third treatment about 3 weeks ago. And now he's been vomiting on a regular basis. So he just stepped up to the restroom.
Okay. Okay. And who's supervising this treatment right now?
This is Dr. Joshi in Castro Valley Oncology, and we are set to go back tomorrow morning for the 4th chemo.
Mm-hmm.
But so far, the chemo is raising about 10 to 12 points after every chemo. It's been raising about 10 points on average, I guess, about 20%.
And what chemo is this that he's doing this time?
He's doing Taxotere.
Mm-hmm. So was there a discussion of other chemos?
He said that he might add something else to the cocktail if this one does not work, which would be, we have to discuss it tomorrow. Yeah. And one of them was Jevtana, and there's the other one. I forget what it's called.
Was it carboplatin?
I think so, yeah.
Right. So, you know, the carboplatin does make a lot of sense. I shouldn't say that. I should say that what I've seen is in men in this situation that adding carboplatin may be positive, but there's a couple of things that I think I would want to get checked first. Secondly, I definitely think that Jevtana is the way to go. If the dose of Taxol is making David sick, and he didn't do great on docetaxel the first time, as I recall, then there's really no reason to be going back to docetaxel when he can get Jevtana, which has, for many men, a much more comfortable and easier side effect profile, and is designed as a second-line chemotherapy after you've done Taxotere. So, I'm not really certain. I'm not really certain why he's doing the Taxotere at all. Remind me again about the issues that David had when he did the. I do remember he had issues when he did chemo the first time. Isn't that right?
Chemo the first time, he didn't have any sickness from it,
I mean,
but it was given to him when his PSA was stable at 1 or 2.
okay.
And there was no sickness. Everything was great. The PSA stayed low.
Okay. Okay, then I was thinking, obviously I was thinking of somebody else. I do have that note actually, but for some reason I thought he had a tough time. So, I mean, I guess one thing is certainly tomorrow to go in and say, do we have to do docetaxel again? Why can't we do cabazitaxel? That's the first thing. The second thing is maybe trying a smaller dose. Some of the guys have had good luck doing a smaller dose. It might be the volume that's causing the problem. The third thing is that before throwing in the carboplatin, it probably would be a good idea to do a genomic sequence and see if there are mutations there that would indicate carboplatin as being the right kind of drug. Has your dad done a sequence before? I can't remember.
No, he has not done a genome sequence. And where do you get that done at?
Well, first of all, you have to have biopsiable spots. So the spots that he has in his shoulder might well be ideal because it's a relatively safe place to take a biopsy from. And if the spots are large enough, then you can just take a bone sample, bone biopsy there, and then you send it off to one of the labs. The lab we usually suggest is Foundation Medicine, but there are other options. But we like Foundation Medicine, or at UCSF they can do it themselves. But the problem with them doing it themselves is it takes about 6 weeks, whereas if you send it to Foundation Medicine, you can turn it around in about 2 weeks. And that could be significant right now. I mean, the Dream Team samples are probably a little better, but I don't think they're significantly improved, or you're going to have more actionable mutations than what you would discover from going to Foundation Medicine. So, I don't know that it's going to make a big difference, and insurance should cover it either way.
Okay, so let me clarify. Tomorrow when we go to get the 4th treatment of docetaxel, can they change it at that time to a different chemotherapy?
Sure. They don't have to give him docetaxel tomorrow. They could definitely give him cabazitaxel.
Okay, so and then the other option is carboplatin.
The other option is to add carboplatin, but I think that the situation with adding carboplatin, you know, I can see why Dr. Joshi would say, well, maybe it would be a good thing to add. I don't disagree, but why not at least do the research to see if it's backed up before you do it? I mean, you can say, well, we'll just do it and see if he works. I mean, that's kind of like, you know, problem for apples.
Right.
On the other hand, you can turn around and say, well, let's do the research. Let's see if we can see a reason to give him, and maybe there's something else that is shown that might be better. And so I would be saying to Joshi, you know, why aren't we doing a bone biopsy here? Let's do a bone biopsy and send it out. And
What about another scan? Do you think that's called for at this time?
well, I mean, I see he did a scan in September,
Right.
right? Which is only 3 months ago.
Right.
So, you know, I don't have I can't tell you, but I'm not necessarily sure that it would be necessary to do a scan.
That makes sense.
I mean, he'd have to discuss it. You should discuss it with him and the interventional radiologist that would do the bone biopsy.
Mm-hmm.
You know, that's one way. The other thing is, the other strategy might be to say, look, this is what I want you to do. Let's just get a dose of cabazitaxel tomorrow and see if Dad does much better with this nausea side effects. We'll talk about the nausea in a minute.
Okay.
And then see how quickly you can get an appointment with Terry. I mean, I know he's ready to go because he asked me where you guys were and why he hadn't.
I know. My dad's not ready to go. That's the problem.
Right. Well, you have to tell your dad he's got to be ready to go because these guys aren't doing the right work. Why didn't they give him cabazitaxel in the first place? Why has he gone through 3 sessions already when he's had this side effect profile and nobody's said, hey, hello, cabazitaxel's got a lower side effect profile. Why aren't we using that? If he wants to be miserable and stick with this local doctor, then that's fine. But you know,
Right.
there's reason, and then you know you get over to Terry and you know, if you can in the next week or so, and see if you can get a genome sequence, which is I think what most doctors who are up to speed would say should be done when your dad's not responding that well to the docetaxel.
I agree.
Let me throw it open for the moment, and then we'll try and tie it up. And I'd also like to ask anybody that's on the call that's done. Is there anybody today? I don't think there is. I was going to ask for people's response on nausea. What's your dad taking for the nausea?
For the nausea, what is he taking? He was taking the compazine.
Mm-hmm.
They did put a Loxy in the chemo last time, but I had to really press for that.
What did you say? I didn't catch. A
Aloxy.
I don't know what that is.
It's called ALOXI.
Oh, Aloxi. Okay, no, I'm not sure. I'm not familiar with that drug. The one I'm thinking of finishes in something Azipan.
Oh, he takes that. That's Ativan, I think.
No. There's another one, and I've got notes on it. Well, let me throw it
And
open.
the Xanax.
No, not that.
No.
No. George, what are the help us out here, George? What are
Ondansetron is probably the most common one
right,
used in nausea. And then some of the benzos like Ativan or diazepam.
diazepam? That's the one I was thinking.
Yeah, that's Valium. Those are probably the two best. You know, if the Zofran doesn't work, then you give a little Ativan. In fact, I just took a Zofran a minute ago because I have nausea all the time, and I find that it works the best.
Mm.
Ask them for the oral disintegrating tablets. So they dissolve right in your mouth. So even if you're throwing up, it'll still get in your system. So it just dissolve right in your mouth.
So which one is that? The Zofran?
The Zofran, yeah, it's very good. It works very well for nausea associated with chemotherapy. Less side effects too than the compazine.
Right. I don't really like the compazine.
That's an older drug, and
yeah, this is the concern I have with the guy that your dad's been seeing. I mean, it just doesn't seem to be up to speed. I mean, this is not a new story. We know this.
Right. He's using the older drug because he doesn't treat specifically only prostate cancer. He treats all types of cancer, and he's running a business with insurance companies. So a lot of the doctors will default to what insurance companies will cover.
Right. Well, the insurance company will absolutely cover cabazitaxel because your dad's had docetaxel, so he's not asking for it the first time around, and that's exactly what it is approved for, and he should be using it. He's probably never even heard of it. Oh, no, he has. He told you that he would look at it.
Yeah, he heard of it.
Well, then why did you use it? This is what it's supposed to be for, and it has a lower side effect profile for most men. Some men don't do well on cabazitaxel, but most men find that it's an easier drug to take. And as far as the nausea is concerned, he's probably treating nausea all the time. For
That's true.
Because that's not prostate cancer specific. So as George says, why is he using an older drug when you've got newer drugs? So, I would say anyway that those are a couple of, let me throw it open and let some other people talk, and then we'll kind of bring it all together. Christina, who else would like to throw out some ideas for David, or talk to David, or talk to Christine, talk to David through Christine?
This is Peter. I've correct me if I'm wrong, but I've always heard that that you can't look for a PSA response as an indicator for this kind of treatment. It's not designed to bring down the PSA like ADT. So if you go through this, maybe his PSA climbing 20% each time is not good. Not a good indicator, but it might not be a terrible indicator for what he's going through. It might still be working. At least that's what I've always heard about people with chemo.
This is Jake. I don't have any experience with chemo, thankfully so far, but your doctor's talking about adding carboplatin. You can also add that to cabazitaxel, and a phase 2 study showed that the two of them together do seem to be better. as far as, you know, long-term survival. With, of course, you know, nausea is one of the side effects, unfortunately, but the two of them combined were better than cabazitaxel by itself. So, you know, if he wants to do that, then maybe he can add that with cabazitaxel. Just a thought.
Yeah, but you know,
Okay, thank you.
like I say, I think I probably would want to get tested as the first thing, just to see, to get a better handle on the nature of this prostate cancer, because it's clearly changed. I mean, it's not the same cancer that was. It's not the same profile of cancer as was treated a year and a half ago with docetaxel. And so, you know, we need to get a handle on what what exactly is driving the cancer right now. And that's what I think is the first thing somebody like Terry Friedlander or one of the other docs at UCSF would be doing. And you know, this is going right over his head, and this guy's just taking pot shots at it by saying, oh, well, you know, if it doesn't work, well, then maybe we'll change to this, and maybe we'll add that. Well, why? My question would be why? On what basis? And if the doc says, well, because he's not responding, I would say, well, why don't we see what sort of mutations he has to try and figure out what the best drug is? I mean, that's where I'm coming. That's where I would be coming from. So I think that if you took a shot of an infusion of cabazitaxel that might hold you through for 2 to 3 weeks, that gives you some breathing space to either do the research, tell Joshi, don't ask him, tell him, I want this done now. I want you to do I want to set up a bone biopsy this week, and let's get it out to Foundation Medicine. The problem is that some of these docs have never done it before, and then they're intimidated, and they don't realize that it's a simple process, it's easy to do, and they faff around. This is the problem we had with Jim Cameron. But it's not brain surgery to do this. Anyone else? Anyone else got any ideas that they'd like to discuss? Unfortunately, David, we just don't have tonight. We don't have a lot of people that have done chemo on the call. That's just the way that it is. George, you did chemo originally, didn't you?
Yeah, I did the Taxotere for 18 weeks.
Right.
I didn't get a whole lot of nausea or vomiting, but I got a pretty severe bone marrow suppression and anemic. I was in the ER about 3 or 4 times during that time too, with chest pain and shortness of breath, and I didn't do very well on it. But I would also like to stress the point that you know, this is such a life-threatening disease that, you know, I would really recommend seeing somebody that's all they do is treat prostate cancer. It's a very, very complex disease. And for a general oncologist to know all the ins and outs is it's a lot to ask of a general oncologist. So I would really recommend, and you know the name of a lot of docs, Rick, that in all the regions of the country that are good. And
well, I should explain, George, that Christine and David has seen, and we convinced him to see a specialized GU med onc at UCSF, who's a terrific guy called Terry Friedlander. He's well known. He's got a great bedside manner, and some of it was around the insurance issues. Now, but that's just been changed. So that's what we were talking about before. So there is somebody set up and waiting to work with David.
I see.
But David has to be agreed that that's where he's got to go. And David, I hope you're hearing that. You know, we all think you need to get back over to see Terry.
And that's what we're doing. Okay. This is a year with the new insurance, and once that all happens, then I'll be sleeping in San Francisco.
Okay. So tell us about your new insurance. What did you sign up for? One of the United Healthcare programs?
It's let me.
It's a PPO through UC Berkeley, retirement.
Okay.
And it's Blue Cross Anthem.
Anthem Blue Cross.
Okay, and it does give you access to UCSF.
Yes.
Okay, terrific, excellent.
Yep, we made sure.
Okay.
Yeah, so
it's a good deal. So we just have to go tomorrow to Joshi and make a decision about this, and then call and see when Terry can get us in.
Right, and if it's a long time, let me know, and I will try and send Terry an email and say, you know, the Sibleys are back in play, and David's going through a rough time, and any chance you could see him sooner rather than later, I'd be happy to do that. But see, first of all, you may be able to get in pretty quickly.
Thank you, Rick.
Yeah, so I mean, we don't want to waste a shot. We don't want to use up a shot if we don't have to. But definitely tomorrow, David, you know, put the full court press on Joshi to do a bone biopsy and order a genome sequencing, and think about doing cabazitaxel instead of docetaxel, and hopefully that'll give you you'll feel better. And as Dr. George says, ask him for some of this self-dissolving Zofran. George, do you take that prophylactically, or do you take it when you feel the nausea coming on?
Well, I mean, because of its expense, sometimes you have to be very sparing about when and how much you use it. So, if you can get a pharmacist to get it to you for wholesale, which is what I do, because my insurance doesn't want to pay for it either. So, luckily, I have a good relationship with my pharmacist, and he sells it to me wholesale. So I can get a box of it for like $20. But if the insurance doesn't pay for it, it can be quite expensive.
Mm-hmm.
So a couple of things you might want to just say is that the compazine is not working, and every time you take it, you throw it back up. And sometimes the doc will have to send in just a letter of prior authorization saying that you can't take the compazine, and sometimes they'll authorize the Zofran. But that's probably the best drug to take. It works very well.
If the program that you're on is a retirement program for UC Berkeley, then a lot of times those programs are pretty generous about how they classify their drugs. I'm assuming, you must have bought a drug program, a Part D program along with the PPO, or was it included in the PPO?
It was included. It wasn't a separate.
Okay. So if it was included, I know that, for example, Professor Bill, there at Roswell Park, their program is very, very generous. in terms. So you can go onto your website and you can look and see what tier that Zofran self-dissolving is, and then it'll give you an idea what you would pay for it. But it's probably not going to be outrageously expensive because this is a Medicare plan. So it's not as bad as for somebody like George who's 54.
Oh, maybe it's this one.
How do you spell that, Zofran?
Zofran. And then George, what type of Zofran is it that he would be looking at?
It's called ODT, which is the oral disintegrating tablet, and it comes in 4 milligrams or 8 milligrams.
Yeah, I put it down.
Yeah.
And is there how would David, or how would they decide whether David should be taking 4 milligrams or 8 milligrams?
Well, you can't really cut it in half, so I mean, I would try to get the 8 if you can. If you can't, then just get the 4. But obviously 8's going to work better. So if you can get the 8, that's probably the better one to use. And you take it every 6 to 8 hours.
Okay.
Okay.
If it's only $20 a box wholesale, I can't imagine that the insurance companies would be balking at that anyway. Isn't that what you said?
It's been around for a long time, too.
Pardon me?
It's been around forever. It's been around for a long time.
Yeah. Well, somebody said it was expensive, but $20 a box doesn't seem that expensive to me, and I can't imagine an insurance company having problems with that.
Is there a generic involved? Or is that it?
Well, the other name is Odancitron. If you want to just tell them the generic name, it's ODANCETRON.
Right. And is it available as a generic, or is it only available as a branded drug?
Oh, yeah.
I'm not sure.
Okay.
Oral?
Oh, yeah. He wants you to do the ODT.
Well, there's the 4 and 8.
Oh, this one, disintegrating.
Okay.
Okay.
They've been going up on prices on generic drugs, believe it or not.
Yeah. No, I've seen that too.
Yeah, I see it on my drug list as the Odancitron oral tablet disintegrating.
Yep.
Yep.
Okay. Well, if it's there, then you just got to tell Joshi you got to tell Joshi that that's what you want. Christine, you have to be assertive.
This is how to write the prescription, I guess. What tier drug it is.
Oh, we're dropped out.
Christine?
This is what tier drug. Yes.
Yeah, I mean, you really, with this shopping list or list of actionable items that you're going to go in with Joshi tomorrow, you're going to need to be fairly assertive that this is what you want to do. You need this Odancitron, you want to do cabazitaxel, and you want to get the tumor sequenced. And, hopefully he's going to respond to you.
Mm-hmm.
Yes, that's what we're going to do.
All right, love.
Thank God you guys were on tonight. We appreciate it.
A pleasure.
Good luck.
Give us an update and tell us how you do, please.
We will definitely keep you updated.
Okay. So anybody else wanted to say anything before we move on?
I was just going to tell you that Paul Frieda has joined us.
Yeah, I see that.
Okay.
Just hold on one sec, guys. Jake, can you handle the meeting for a second, or Peter?
Yeah.
I'm sorry.
Did anybody else have any more comments for Christine and Dave? Why don't we just hang loose for a minute? I'm not sure where Rick went. I guess he's going to go find a piece of paper or something. Did you get all the spellings correctly on those drugs, Christine?
Yes, we did. I really appreciate all your feedback. Thank you very much. And Happy New Year to everybody.
Well, thank you. Happy New Year to you. And Happy New Year to everyone, by the way.
Yes, I second that.
I third that.
Anybody at wild parties last night?
Not me.
No hangovers?
I'm not even sure if I was awake at 12 o'clock last night, to be honest. It's, those days are long gone for me. I don't really, I'm not a party goer anyway. I have to be careful.
Awake at midnight only because of all the noise, firecrackers, and gunshots.
Well, yeah, that. Would you believe, we have this like 10, 15 degrees here, and some idiot was out riding his motorcycle at 12 o'clock last night. I couldn't believe it.
Oh, wow.
Well, that's probably not a bad time. Probably 12:30 would be a bad time.
Well, I mean, riding a motorcycle in this kind of cold weather, that's a little bit excessive, I think. I understand being a lover of motorcycles, but I don't understand driving it in frigid cold weather with snow on the roads to boot.
I guess you don't live in California.
No. I live in Maryland. It's 15 degrees last night with snow on the road, and we did have some guys with shooting gunshots and fireworks. That's okay. I understand that, but the motorcycle, no, I don't understand that.
I don't think so.
Yeah, not there.
I thought it was pretty special last night having a full moon for New Year's.
Yeah.
Yeah, that's right. It's full moon. What's it called? Harvest moon? No, not harvest moon.
No, I was out on my girlfriend's deck watching 180 degrees of fireworks from up on high. It was pretty amazing. It felt kind of like I was in Syria or something. And it was a lot of explosives and big shells going off.
Huh.
I'll tell you two things here. One is that we celebrated in the typical Arizona fashion, which is because I couldn't understand how anybody out here was ever going to stay up till midnight. So we went to a party and they celebrated it at Eastern time, which was 10 o'clock here, and then they all went home.
That's perfect.
So that was the first thing. The other thing was that a friend of mine, I was telling Jake when we started, a friend of mine had been dog sitting and lost a dog way out in Madeira Canyon, which is pretty remote, and the dog had taken off, and Saturday we'd been looking, and the people that own the house came back and arrived home at 3 a.m. in the morning and immediately went out bushwhacking under the light of the full moon and found the dog at about 5:30 this morning. The dog had a leash and the leash had gotten caught under a rock and was accompanied by another dog they have, which is a kind of semi-wild dog. That they had adopted about 5 or 6 years ago. They found it on the side of the road, and it's kind of like a coyote, and hard to handle. And the other dog had stayed right by the side of the dog with the leash on the whole time, which was a good thing because I was basically protecting him. But anyway, that was the story. I'm sorry, guys. That was my landlady banging on my door. They want me to go over and meet some guests they have, and she texted me earlier on, and I was texting her back during the call and said I can't do it, but I apologize for that. But that's why we have Jake and Peter and Len. By the way, sent his apologies. he's driving down to Virginia from New York and putting their car on the train to Florida tomorrow. And then he'll be in Sarasota, Florida for the next 3 months, which is a tough life, I guess. But
tough life.
Tough life, but somebody's got to do it, right, Rick?
that's right. That's right. Jake, you should have offered to carry his bags.
Really?
Yeah.
Actually, my son's down in Florida right now with his in-laws.
Well, there you
Lucky
go,
dog.
man. There you go.
Yeah.
All right. So, I think we've given you about as much as we can, David, and I really hope we can help you turn this around a little bit, feel more comfortable, feel better, and with a bit of luck, we may even find a mutation that is actionable. I mean, I see these numbers running anywhere from 10% up to 35% and higher, where they're finding actionable mutations. And a lot of it is marketing, but there's no question that as prostate cancer, which is the only one I know well enough to talk about, mutates, it does throw out a bunch of actionable mutated genes. And every day there are more and more drugs becoming available, mostly off-label. And one of the things about those off-label drugs is you've got to have a medical oncologist who's willing to go to bat for you, and which I think you will definitely find at UCSF, because it's hard where you've got a guy like Joshi who's just got a local practice, and you're trying to get an off-label drug because he just doesn't have the time, and he doesn't get paid to do all that extra work. So let's hope that we find something that's actionable for you. Okay. Paul, Happy New Year. Anything you'd like to bring up tonight?
No, I don't think so. I don't have anything.
Okay.
Thank you.
So
Happy New Year, everybody.
Happy New Year. Peter, tell us about this test.
Yeah, I have a friend who I've been communicating, a very old friend that I've been communicating with who's in California, and I sent him to see Dr. Gary Leach over at Tower Urology because he was having urinary problems and his PSA was climbing pretty significantly. Anyway, but he did he hasn't had a biopsy yet. Gary wanted to do a biopsy on him, but this guy's resistant to that. But he had what's called a PSI test, and I suppose it's something I should know, but I tried looking it up. I couldn't find it, and it's not familiar to me. They said he had a PSI test, and it came back at a 15% chance of cancer, and he said it seems low enough that he's willing to take the risk of just riding it out for a while and not doing any biopsy. So do you know what PSI is?
Yeah, it's a combination of 3 tests: a PSA, free PSA, and I think the what's it called? the P3 PSA. What is it? PSA P3.
Yeah, I know that one. Yeah, I know that one.
What's it called? Yeah. What's it called, Peter?
I'm losing it right now, but it'll come to me. And
I think it's all 3 of them, and then they have an index that they create out of those 3 tests, and they score the probability off of that. But I'll be honest, it's not something that I'm particularly familiar with, because it's a typical test for people that are newly diagnosed with low-grade cancer, which is not my strength. So, but I know what it is.
Okay. Yeah, I tried looking it up and I couldn't find a definitive answer for it. But okay, makes sense.
Okay. No, there's. I'll see if I've got a. I mean, I'm sure I've got a reference on it somewhere. And and I'll get it out. If I find the reference on it, I'll get it out to you. I'm sure there's stuff on prostate cancer info link on it too.
I think the other one's a 3K test or something, right?
No, it's not called 3K. It's called. It'll come back to me in a second, but it's the one where they massage your prostate,
Oh, okay.
and then you pee, and so they just get they get prostatic fluid, and they're able to make some judgments from the prostatic fluid.
Okay.
P3PCA, is that it? Boy, we got the wrong group on tonight. No one can help.
No, I had the one where they massage your prostate and they test your urine, but and I forget what it's called too. But as Rick said, it's really for newly diagnosed people to see. It gives them an indication of whether they think you should get a biopsy or further studies. That's all it is. Is an indicator.
That's exactly where this guy is. He's trying to figure out he's got strong ideas of not go. He doesn't want to go the medical route, so he's being very cautious. But again, I tried looking it up, but I couldn't get anywhere. So I'm just asking. Okay,
well,
that answers the.
It's interesting that you talk about the non-medical route, because I was talking to a woman at this party I was at last night, and she was a breast cancer survivor. And she said she has a friend whose name is Tara Coyote, and I have a sneaking suspicion it's Peter. I have a sneaking suspicion it's Peter Coyote's daughter, because she lives in California and she used to live in San Anselmo, Marin, which is where Peter Coyote lives. I don't know if you guys are familiar with Peter Coyote. He's an actor. He does a lot of voiceovers. He does a lot of nature voiceovers for nature stuff and what have you. He's been around a long time. And my guess is it's his daughter, but I'm not certain, because it's kind of an unusual name. I don't know him directly, but I actually know his personal assistant. Who's been his personal assistant for years and years. She lives next door to my buddy Dave. And this woman, Tara Coyote, she was diagnosed with stage 3 breast cancer, and she's only done complementary treatments, and she's brought her stage 3 breast cancer under control. And, it's hard to know how viable that is without knowing the actual details of stage 3 and who diagnosed it at stage 3. Was it truly stage 3? And it's always difficult to ask questions because people are so they're so convinced about these non-Western treatments that you can't really question. I mean, you guys know what I'm saying. I'm sure that people come in and they're proselytizing all these great means of treating cancer through complementary and Eastern medicine, which, as most of you know, I'm fully in support of, but I don't think it works alone. But here's a woman who seems to have made it work for her breast cancer, and I was asked, did I want to talk to her? And I say, what I did say was, look, if she wants to set up a group for complementary medicine and she wants to use our platform to do it, I'd be happy to support her to do that. But I'm not a person that really thinks that complementary medicine of itself can treat aggressive cancers. But who knows? So, all right. Peter, anything else?
No, I think that's about it. I'm going to do a blood test in about a little over a week, and I should know more about my own journey then. It's kind of where I am.
Right.
I've made reservations to be in San Francisco the last of February, beginning of March, and if I need to do any tests, then that's when I'll do it.
Okay. But but you're monitoring yourself until then, and you're testing locally, right?
Yes. Yep.
And have you ever?
I've got 2 month doubling time right now.
Right.
I mean, my numbers are very low, but my doubling time is 2 months.
Right. Have you ever done a test either in San Francisco or in Marina del Rey, and then immediately done another test as soon as you came home to see what the variance is between the labs?
No, I've not done that, but I find I get a complete blood test in Marina del Rey every 6 months, and it's very, within a hundredth or a couple of hundredths of my blood test here, so it's pretty darn close.
Okay.
When I do the following month. I mean, I've never done one immediately after, but they seem there's not a wide variation.
Okay.
It's very, very narrow.
So you're pretty comfortable with the with the different labs. You can reconcile the local Hawaii lab to the California labs.
Yeah, I think it's pretty accurate. I don't think they're making these numbers up. I think it's yeah, I think they're on it. That's my guess.
Now I have an important question for you. What was the Hawaiian that Rob Beniscus wrote back to you yesterday? Was that Happy New Year?
Happy New Year, yes.
Okay, can you say it? Can you say it for us?
I've never been able to say it.
Okay. Okay, I should share with the guys that we had a little interaction yesterday between a bunch of us regarding the press release that I hope some of you saw today, and Peter and Rob responded with Happy New Year in Hawaiian, and that's what I was asking about. So anyway, yes.
Peter, you might check in the chat box. I just put a link to the Cancer Society talk about other tests. I think your friend might have been talking about the PHI rather than PSI.
Okay, I'll check on it.
You could be.
There is a little discussion. There's a little discussion about the prostate health index, PHI, and the 4K score test, which is the one I think Rick was mentioning.
Okay.
Is that the one you were talking about, Rick? 4K?
I was thinking of the PHI, but I could easily have been confused. Easily.
Well, I can't find anything about PSI either. So, but there is a PHI.
Okay. The only PSI I know is what goes in my tires. Maybe he's got an inflated prostate. Who knows? And he's checking the pressure of his prostate. They measure it in PSI. Could it be, Peter?
No, I don't think so.
You don't think so? Okay. Just a thought, Peter. Okay. Peter, would you let your local people know about our breast cancer group starting?
Yes, I will.
Thank you very much. Okay. Dr. George, tell us what your agenda is for your with your doctor on this week.
Well, I go see Dr. Ferrari on Wednesday. I'm not sure what the plan's going to be. I think it's just going to be to watch the PSA. I had the recent biopsy of the prostate, which was totally negative. So the thought was to do a prostatectomy or radiation to the prostate. However, that's now not necessary. So I think we're just going to watch the PSA. it was elevated, but it may have been due to the biopsy. I'm not sure how high it can go after a biopsy, but it went from a 0.03 to a 0.12. And that was about 2 weeks after the biopsy. So they didn't seem too concerned about it. I'll just have to wait and see what the next PSA is.
So you missed, I know you came in a little bit late. We had the first 15 minutes or so, we had an extensive conversation about this with Tom Van Zandt. Tom asked, what's the sense of debulking? And he gets a lot of pushback on the debulking from his people, from his medical team at Fox Chase. And we did talk at length about that.
Yeah, I think they've shown increased survival with that, and they're doing more studies on it. But I think the studies now are showing that it's going to add to survival.
Do you? I know I have a link and I couldn't quite find it. I need to spend some time afterwards. But do you have links to any of those studies you could share with Tom?
I can find them, and they're not very large studies. So I think there's probably a lot more in the works, but I can send you what I have.
That would be great, and I will look, Tom. As I said, I'll look for the Memorial Sloan Kettering study, which I think is the watershed study from a couple of years ago that really got people thinking about debulking, albeit that was surgical and not radiation. But do you have any questions for George, since the two of you guys are in a very, very similar position? What's your PSA right now, Tom?
It's less than 0 right now.
It's less than 0. Okay.
Good.
And that's what the doctors say to me. I ask about debulking, and they say, well, you're less than 0, you're in a good remission, you're on Zytiga, you have metastases to lymph nodes throughout your abdominal area. It's just not it's not for you. They say debulking is not for you. It's asking for trouble, asking for complications.
Is that the only place you have the prostate cancer right now? You have it in the bone?
Not that I know of, no, just in lymph nodes.
It's, again, I wonder, since you don't have it in the bone, I just wonder about pelvic girdle radiation for you.
Yeah.
It's something.
Well, when I was at Memorial Sloan very early on in this whole procedure, they took a very close look, and they were flirting with the idea of doing some radiation. And I remember the doctor was on the phone with radiation, and then they said, no, in your case, it's in, I guess, so many lymph nodes that the amount of radiation they would have to use would do too much peripheral damage. And so they just wanted to use Lupron.
They were on Lupron and Zytiga?
Yes.
That might not be the case right now, Tom, and maybe you can be talking to them about another scan and seeing if the Lupron and Zytiga has reduced the evidence of lymphatic involvement to the point where radiation may be an option at this point.
Yeah, I had asked about when I would get another scan, and the answers seem to be you won't get another scan until your PSA starts rising, or you have complaints of bone pain or whatever.
If that was me, I would try to find I would get another opinion. That's just me. I just don't like this. I never liked the idea to begin with of having bone mets and being told that, you know, you'll get on Lupron for the rest of your life, and we'll see what happens, and we'll wait for your PSA to go back up, and then we'll try something else. It sounded like I was on the road to palliative care, and until I found somebody that was aggressive enough to go and get the cancer, I mean, but that's just me. I don't know. It's everybody's individual, but I'm willing to put up with a lot of suffering up front, you know, knowing that it's going to be worth it in the end. That's just me, but
Well, that's what I was told is, in my case, palliative care is all I was going to get.
yeah, I think that the whole reason for this, doing these combination therapies and these debulkings and taking the prostate out or radiating it is it does increase survival. I think they're going to find that. I don't know. I just think that I think our approach to prostate cancer has been wrong for so long.
Well, you know, I do want to say, and I'd like a few more people to come into this conversation, that when the doctors talk to you about palliative care, they're not talking about end of life palliative care. They're talking about, I hear them talking about more about managing your disease, because they recognize your disease can't be cured, which I think we all acknowledge. The disease can't be cured, but it can be managed for a very long time for many men. Not for all men, but for many men. So palliative care to me means that we're going to manage this disease with the least amount of discomfort and pain for as many of you as we can. They're not talking about end of life care. That's how I hear it. But, you know, maybe can we get a discussion going around that?
Well, I know I initially became very concerned when I was diagnosed, and I was scheduled for surgery to have the prostate removed until they saw the lymph node involvement, and then they canceled the surgery, and they said, we want you to go see the radiation people. And I went to see them, and they looked at all my records and tests, and they said, oh, we can't help you. And they sent me to, I forget who else next, but they said, we can't help you, and it's just going to be palliative care. And it scares the hell out of you at the time until you understand it a little better. It's, as Richard said, it's ride it out as long as you can, and, you know, try and maintain a quality of life. But then I started hearing about this debulking, and it always bothered me to just leave this tumor alone, even if it's controlled by cutting off the testosterone. Why not attack it a little bit was what I was thinking. But every time I bring it up, they say, oh, don't worry about that. You know, you're doing fine.
This is Jake. First of all, Lupron itself, and almost all of us are on Lupron, they tell you it's not a curative drug, it's a palliative drug. It's you know, so palliative does not mean, like Rick says, it doesn't mean end of life. It just means it's to control basically your cancer. And you mentioned scans. Some scans won't show anything when you have a very low PSA. Some of them are not sensitive enough to even show mets that are under control. And if you've got a 0 PSA right now, chances are most scans wouldn't show anything. Am I right about that, Rick?
Yep. I mean, you know, the Axumin is as being readily available, probably has about the lowest. Our friend Ellen Edel published something recently showing the lowest thresholds. But I think in most cases you're going to need to be up around 0.5 to see stuff. But you know, again, it depends on the man. We have men who make very little PSA and have metastasis. So generalization.
Rick, can you get a little closer to your mic? You're kind of muffled and very low.
Let me turn my volume up. Yeah, I'm just saying that it's a generalization, but probably you need to be around the lowest end, even for the gallium PSMA scans. You probably need to be somewhere around 0.5. Maybe, if I remember correctly, the gallium PSA scan may be good at around 0.2. Don't quote me on that. I'd have to look. I honestly can't remember.
So, Jake,
Yes.
be careful. I wouldn't use the word palliative and Lupron in the same sentence, just because palliative relates to. I mean, I understand your thinking, and I think a little bit that way too. But palliative relates to easing pain without necessarily curing, whereas most of us who've been on Lupron, I don't know if I'd call it easing pain. It just sometimes causes more problems than we bargained for.
Well, that's true.
It's not so much pain, but it's a whole separate thing because it eases symptoms or some indications, not so much pain.
Well, that's a good point, Peter. But what I was just basically, and I agree with you. You're 100% right. But if you look at the Lupron site itself, that they refer to it as a palliative drug.
Really? Amazing.
Yes.
Interesting.
Unless they've changed it recently. The last time I looked, and I've looked several times since I started taking it, they use the term palliative.
Ah, it's very interesting.
Yeah.
I mean, Peter, that's the confusion that I was referring to before. That you just have to have a wide definition of palliative when you hear that word.
Right.
Right.
So I'm wondering, can ADT starve? I mean, starve the cancer cells so that they actually die off? I mean, is that something that ADT does so that it's not actually palliative, it's actually aggressive?
Anybody else want to go have a shot at answering that before I do?
Well, it definitely is aggressive, but it's not necessarily curative. I mean, I was on for 18 months. I've stopped. Now things are creeping back in again, so I probably have to go back on some kind of ADT. So it's I don't think. I think in very low grade cancers, it probably helps in the curative process, but in more aggressive cancers, it's more of an aggressive treatment that stems the tide or holds things back a ways, I think, but not necessarily cures anything.
Right. That's my understanding too. And in fact, since I started taking it over 5 years ago, they've expanded the use of ADT to other situations, and they use it as an adjunct to other treatments, and in the hopes that it will kill the cancer. So the palliative term that they used to use may not be appropriate anymore. Peter may have it makes a very valid point. Somebody like me, it's going to keep the cancer at bay, hopefully for a long time, and it does. You starve the testosterone, you starve your body of testosterone, which is what the prostate cancer likes to feed on, and it does work, and it does do that. But in my case, it's not going to ever kill it completely. With other people who are getting radiation up front, they're getting the chemo up front, it may be a whole different story. And that's what they're hoping for. I think that's what they're shooting for, is to kill it up front with all the multiple modalities of treatments. That answer your question, Gary?
Yeah, I just met somebody who said he's been on ADT for 9 years, and he said it's actually, in his mind, it's starved the cancer, and he thinks he's cancer free at this point, and um, that it actually killed it. So it made me wonder if that's what it does.
Well, the fact that he's still on the Lupron should tell you that the doctor doesn't think it's been completely killed, or they wouldn't keep him on the Lupron indefinitely.
Yeah.
Did he have a high-pitched voice?
That was amazing. 9 years on ADT. I was like, wow, holy cow.
I think, we have men on this call who have been on for even longer. I think, Gary, that what it tends to do is it puts the cancer in remission. It starves these cells so that they cannot actively reproduce, but it doesn't kill them off necessarily. So if he can handle the ADT, he can control his cancer for a very long period of time. Most men will become castrate resistant over a period of time like that, but not all men. And castrate resistance means that the cancer continues to grow even though it's being starved of testosterone. So I don't think we can say that the ADT kills the cancer. We can say the ADT places it in a dormant state. And a lot of people will say, well, why even bother? And I've heard the argument, well, when it comes back, it picks up in a much more aggressive fashion than it did before. That could well be true because the cancer's changed, having been submitted to this starvation for so long. But having said that, when you have advanced prostate cancer, the name of the game is to get the most out of every drug that you possibly can. So if you can handle the ADT, and some men cannot, like Dr. George is a good example. It's very hard for Dr. George to be on ADT. But you get as much as you can out of each stage without before it continues. But I agree with Jake that I doubt that your friend's cured. He's in a controlled remission induced by the androgen deprivation therapy. If he stopped taking it, let him go on a holiday after 9 years, see what happens.
Right. And Rick, you mentioned, castrate resistant on Lupron, but even then, most men still continue taking Lupron. The PSA starts rising, and it's not complete. Right. They never stop it completely. They just add new drugs.
Correct.
So the Lupron does have an effect even after you're castrate resistant.
Right. But I want to come back to Dr. George, because I think that the $64,000 question, George, when you see Ferrari. She must be a fast stock.
She's getting up there in age. I hope she doesn't retire soon.
Okay, just tell her to put in a new engine. I think the $64,000 question is the one that Peter's facing. Is, well, at what point should I consider restarting more active treatment? Because you've been off of your ADT now for a year, isn't that right?
Yeah, it's been over a year.
And you're doing great. Your PSA is at 0.12. Now, we don't know if you'd even want to go back on ADT. That's another discussion we can have, because we recognize the side effects with you. But I always recommend to guys who are in your situation, have a PSA threshold at which point you're going to start talking about what should I do next, which is what Peter was saying just before, right, Peter? That you've had this
Yes.
discussion with Dr. Turner, and when you get to point 5, you know you're going to do something.
Right. Right.
So what would you say to George?
Well, we're in a little bit different situation because George is metastatic, and
Right.
I'm trying to keep from getting metastatic, but something's on the rise. Yeah, I would have an agreement with my medical oncologist at what point to go for further scans, maybe a high-tech scan that can pick things up. And my doc and I agreed that at 0.5, I'll start with an oxygen scan and see if that picks up where the activity is. Right. My last test I was at 3.4. And my guess is that I'll reach 0.5 sometime in early February, but I don't know. That's just a wild guess. I mean, I would love to get a blood test next week and find out that it's stable at 0.34. But just by the progression the last 3 months, I'm suspicious of that. So I just watch it carefully. Do you get your blood tested how often do you get your blood tested, George?
I was getting it every month, and now it's every 6 weeks, so it's still fairly closely.
Yeah, not the same as me. I go every month. So yeah. So you're doing the right thing. You're keeping an eye on it, and you got it. It's got to be up more than 0.115 or whatever you have now to really get an accurate scan's not going to do any good at this point. You've got to get it up at least 0.5 or so to really get a good reading on where the activity is, if there is anything indeed. Maybe things are really stable and you're fine.
Yeah, well, the insurance wouldn't pay for the really good bone scan. She's talking about doing a prostate MRI, but she's really got a low threshold to put me back on it, and I can understand because of my bone mets. So if it starts going up, I don't have any problem going back on the ADT. I certainly wouldn't want it to get out of control. And which is why I'm keeping a good eye on it. And if it does go up, then we'll have to talk about going back on it.
George, when was the last time you did a bone scan?
I get them at least twice a year now.
Okay. Okay.
And I just got one about 3 months ago.
Okay. Yeah, I mean,
it's fine.
I think it's just it's really smart to do exactly, and you're doing all the right stuff. I mean, don't go longer than 6 months without a bone scan, because the PSA, as we said earlier in this call, the PSA may not always be the best measure. What you really want to see is what's the cancer doing.
Yeah, and one thing I learned about the mutation is I guess there's about 1% of people that have a low PSA, and the cancer continues to grow, and it's a neuroendocrine type, which is very aggressive, and that's the other thing, is that you can't base it all on the PSA.
Right.
You got to do the CAT scans and the bone scans.
Right. I mean, Jim, who's at Rutgers? Who's at your hospital? Jesus, why am I blanking on his name? Somebody help me. No?
Jim Harrington?
Jim Harrington.
Jim Harrington?
Yeah, Jim Harrington is in that category. Very low PSAs. I mean, higher than 0.1, but low PSAs, extensive bone mets, makes very little PSA. And Eric, Jesus,
Eric Bookbinder.
Eric Bookbinder is another guy who, well, now, I mean, he's had times now where his PSA has really gone high, but but he's another guy that's like that. So yeah, I mean, we know plenty of guys that don't make PSA have extensive meds. What's your Alk Phos doing?
That's been stable. That's been low. I cracked some ribs last year in Florida, so I fell off a bike and of course my bone scan lit up on one side, and that stayed lit up for about a year, actually.
That's my specialty. I'm very good at that.
And I wasn't even moving. I
I
had just gotten on the bike.
Been there. I got that T-shirt. I went through a wash on Saturday. I was so proud of myself. I went through this wash, and it was soft sand. I thought, this is great. I got up the other side, and I saw I was heading towards this tree, so I stopped, and I was like, stable, stopped, and that's when I fell off the bike. So I always managed to land on my bad hip. So I hate to think what that bad hip would look like if I did one of these bone scans right now. It'd be like a searchlight beam.
Uh-huh.
So anyway, not for much longer. It's about to get replaced. So which is good news. All right. Well, I just wanted to throw some ideas out for you to talk to Dr. Ferrari about, but I do think it's a really good idea to have an objective in mind, a point in mind, and I also think that you're doing great. You're doing really great. I mean, if we could get your head going as well as we got your cancer going or not going, we'd have success. We'd never have to speak to you again, right?
That's right. That's right.
Okay. So just a couple of little things, because we're coming towards the end of the call. One is, I'm sorry to sound like a broken record, but please do whatever you can to let people know about the new breast cancer calls. I tweeted them out. I tweeted out that press release that Rob prepared to Kaiser Health News and Kaiser Foundation, Family Foundation, and anybody that I could possibly think of that might have an interest in health news. And if anybody has any ideas or has any relationship to health journalists they think might be interested in our story, it would be really great to let us know, and we can get them involved. Secondly, I don't know if there's anybody on the call right now that was not on the call on Thursday night, the inner conversation. No, excuse me, last Tuesday's call, but we are definitely moving forward with the clinical trials effort that Larry proposed, where we will be reviewing prostate cancer related clinical trials and highlighting those that we think have value. That there's a working committee which involves Dr. George and Len Sierra and Larry Fish and Jeff Ledoux, and we'll be asking if there's anybody else that would like to join that committee. And the four of them are really going to get together and figure out how we go about this. I've invited Peter to contribute if he feels like it, or if not, to ask any of his guys that are on the low and intermediate call if they would like to join and have a focus on the tests that are being offered for low and intermediate men. There's a lot of active surveillance tests for people with low risk disease, and there are lots of trials going on for regarding robotics, regarding radical prostatectomies of whatever type and radiation and what have you. That's not a focus where the guys on this call are going to spend much time, but it would be nice if we could get a small working team together to focus on that, if there's anybody out there that's interested in doing it. And I'm really excited. And the only stipulation that I've really placed is that whatever we come up with is easily is easily transferable and understandable in a written form, so we can put it on the website, so people can use the reference page on the website. So we'll be moving forward with that. I think it's going to again help us to distinguish from the pack, and then we'll just see how long yet again it takes for them to copy what we're doing. And that's about it. So Happy New Year to everybody. I hope it is healthy for all of you. And the next call will be Tuesday the 9th, week from tomorrow. And I'll look forward to speaking to all of you then, or if not before. Anything
Can
else?
you tell us a little bit about Wednesday? What's coming up on Wednesday? And what time is it going to be?
What's coming up on Wednesday?
Oh, it's reconnect. We've had a couple times it had to reconnect.
What? I'm not sure.
Gary, that's the inner conversations.
Oh, Wednesday.
On Wednesday.
Oh, thank you. Okay.
It's for this coming one is at 8 o'clock. They're all at 8 o'clock now. Our usual Thursday meeting have all been moved to Wednesdays, but the first and third Wednesday is all cancers. The second and fourth is prostate cancer only.
Okay.
That's the one you've been participating in. But I think there is something else at 6 o'clock on Wednesday, isn't there, Rick? Hang on, let me check the calendar real quick here.
No, there is. I don't think so. Wednesday was a completely open day, and John grabbed it.
Okay.
So, but thank you for reminding me, because I have to post the on Inspire. I have to post the Inner Conversations call that's open to everybody, and I will do that. But you know, all of you prostate guys are very welcome on the general call. I don't know, it's going to take us a little while to pick up steam there. But if you have any friends that are wrestling with cancer that is not prostate, you know, God forbid lung or colorectal or melanoma or anything like that, and they're having difficulty reconciling themselves to the cancer, then this is the call for them, the first and third Mondays. And we'll be working with them to laugh a little bit and to unpack some of the issues around that. So Gary,
Can I ask? I'd like to ask another question, and that's about. I haven't heard from Jim Cameron, and I don't know why. I'm wondering how he's doing and worry about him, I guess.
Jim Cameron, yeah,
Yeah.
and yes, I meant to write to him yesterday and I forgot. I don't know. I haven't heard from Pam, and I will check in. He wasn't doing great, but I haven't sent anything out to him, and we'll find out. I mean, you know, sadly he had to get a bag. He had to get an ostomy bag, and we'll see how he's doing with that. But I will try and get an update. I'm making notes here of Jim Cameron. I will try and handle that later tonight or tomorrow.
How about Eric? Have you heard from him at all?
I have. I'm trying to think if it was offline or not. But he was doing relatively well, you know, as good as can be expected. I will tell you about Dr. Steve. I did promise that earlier on. Steve is set up on in about 3 weeks to start lutetium 177 PSMA trial in Los Angeles.
Oh, good.
And this is but this is a private trial. He's actually been talking to the people that make the I forget what you would call it. It's not really a contrast. It's the medium that allows that seeks out the PSMA and to which the lutetium attaches. And there will be lutetium 177 trials opening about a year from now here. But they're not ready yet. So what Steve is doing is doing this privately. It's going to run him $7,000 to $10,000 a shot, and he's going to see how it does. Now, you know, it's very expensive, but also bear in mind that he's basically paid nothing at all to date for all of his health care. So that doesn't alleviate the pain of the expense, but he's really had a good run, and you know, he's been very fortunate to date. But I don't think he was able to get Kaiser to pick this one up.
Oh, good luck to him.
He'll be on. I think he'll probably be on the call next Tuesday, would be my guess. So he sounded good. He sounded very good when I spoke to him last. All right, guys. I'm going to say good night. I got to get over to see these
Good night.
the way. Okay. Good night, everybody.
Thanks.
Bye.
Thanks, Rick. Happy New Year, everyone.
Bye.